This is Jeff Streisek. On behalf of myself, Dr. Christopher Malucci, and Dr. James Hare, I'm going to present a case of spinal epidural abscess as a supplement to our chapter in the 8th edition of Humans and Wind Neurological Surgery. Spinal epidural abscess is an important clinical entity for any neurosurgeon to be aware of and to be familiar with. The objectives of this discussion are to present and encourage understanding of some of the common presenting symptoms of spinal epidural abscess, to present and for the learner to understand the tools available for establishing a diagnosis of spinal epidural abscess, and then for the listener to understand some of the management options for treatment of spinal epidural abscess. This is a case of a 37-year-old male who presented to the emergency room for evaluation of progressively worsening back pain located in the middle portion of his back that he had been experiencing for approximately 1 week. His past medical history was unremarkable, no history of diabetes, hypertension, or any other medical comorbidities. His social history was significant for IV drug use, specifically heroin, which he had been a user for many years, most recently 1 day prior to presentation, as well as alcohol and tobacco use. He did not take any prescription medications at home. In further conversation with the patient, in addition to the mid-back pain that he presented with, he also described thoracic radiculopathy, which characterized as a sharp pain wrapping around the left side of his chest and into the front. He also noticed this pain on the right-hand side, however, it was worse on the left. He denied any subjective symptoms of bowel or bladder incontinence prior to presentation. On his neurological exam, the patient was full strength in all muscle groups in the bilateral upper extremities. In the lower extremities, the patient had some mild weakness in the bilateral iliopsoas, approximately 4 out of 5, which he attributed to pain-limited weakness from his back pain. The remainder of his muscle groups in the lower extremities were rated 5 out of 5 strength. His reflexes were unremarkable. There were no pathological reflexes, including Babinski or Hoffman's. Sensation to both light touch and pinprick were intact in the bilateral upper and lower extremities, and his rectal tone, sensation, and volition were also intact. Additional objective data on this patient included a temperature of 99.8 degrees Fahrenheit, a mildly elevated white count of 14.4. The normal reference ranges for the laboratory which performed these tests are included in parentheses. A CRP value which was quite elevated at 19.1, and an ESR which was somewhat elevated at 39. Given the patient's clinical presentation, his laboratory results, and his risk factors including IV drug use, he underwent emergent MR imaging of the spine. This is a T2 weighted sagittal MRI of the lumbar spine, in which an epidural collection is visible ventral to the conus at the level of T12. This is further imaging of the spine that was obtained in this patient. On the left-hand side is a T2 weighted sagittal view of the thoracic spine. On the right is a STIR image of the thoracic spine as well. Using the ventral abscess that was identified in the lumbar sequence in the slide before as a counting reference, we can see that there is an epidural collection located dorsal to the spinal cord that spans as high as T2 and extends down to approximately at least the T11, T12 level in these single cuts. This STIR image was selected because it does not show any current sign of spinal cord edema. The other important thing to note in both this set of imaging as well as the set of imaging prior to this is that the discs don't show any significant amount of T2 hyperintensity, suggesting that this is not a case of osteodiscitis that has spread into the epidural space, but rather that this is infection that has directly seeded the epidural space. This slide contains two post-contrast axial cuts through levels at the thoracolumbar junction. In the image on the left, you can see that there are rim-enhancing collections, both dorsal and ventral, to the spine and to the level of the spinal cord. This is not at the level of the nerve roots. And that'll be important in a minute here. On the right-hand side, you can see that there is a rim-enhancing collection that is exclusively ventral to the cord, and this is at the T11, T12 disc space level, which is important because it's still at the level of the conus. The imaging included here is both thoracic and lumbar, which is important because we can see that people can have multiple abscesses or significant abscess burden extending over multiple levels. Not included in here but reviewed prior to this patient's surgery was an MRI of the cervical spine, which was negative for any sort of epidural abscess. As discussed in the chapter text, there's a significant number of patients with epidural abscess who can have non-contiguous abscesses, so it is important to evaluate the entire spine to locate multiple sources of infection. Another set of imaging that was not obtained in this patient but also could be obtained in the process of working up a patient for epidural abscess would be a CT scan of the affected levels. Given the patient's MR imaging without any sign of osteodiscitis, CT imaging was foregone in this situation. However, if somebody did have significant burden of infection within a disc space or involving the bones, CT scan would be helpful for operative planning to understand levels of instability and the need for further instrumentation or possible vertebral body reconstruction of one form or another. So to recap, this is a 37-year-old male with an extensive thoracolumbar epidural abscess located in both dorsal and ventral to the spinal cord, in setting of IV drug use with a new neurological deficit and manifested as proximal lower extremity weakness. So now we have to plan the best course of action in treating him. For this patient, we elected to go forward with surgical decompression. The text of the chapter talks a little bit more about the nuances of medical versus surgical decision-making and the evidence behind each of those decisions. For this gentleman, given the presence of a neurological deficit as well as the location of the abscess in the thoracic spine, we believe that surgical intervention was the most prudent option moving forward. Having settled on that, goals of surgery: number one, decompression of the neuroma elements and evacuation of the abscess. A second goal obtained through or achieved through the process of decompression is collection of samples for culture to identify an organism and tailor antibiotic therapy in the postoperative setting. To decompress the neural elements in this patient, for the large thoracic component that is located dorsal to the spinal cord, a laminectomy would achieve those goals. However, down at the T12 L1 level, where there's abscess located ventral to the cord, a laminectomy is not going to be sufficient, as we would want to avoid thecal sac retraction, as it's at the level of the conus, and retraction there would increase the risk of neurological injury. So at that lower level of the abscess, we need to plan to do some sort of procedure that would allow us access to the ventral epidural space. In this situation, we planned on taking down the pedicle on the left-hand side to take out abscess that was wrapping around the left-hand side of the epidural space, but also allow us to look in front of the cord and evacuate abscess there. The patient would not necessarily require any stabilization from the result of his infection in and of itself, given the absence of any significant osteodiscitis or bony destruction or resulting kyphotic deformity. However, the process of taking down the pedicle to access the ventral epidural abscess, we will iatrogenically destabilize him. Thus, a fusion procedure was planned to address that destabilization. In the process of instrumenting him, we also would plan for arthrodesis using a posterior lateral technique across the transverse processes, And then we also have to ask ourselves, is there any need to do correct alignment? Given the absence of the osteodiscitis or significant deformity, there is no role for correction of alignment in the clinical situation here. These are postoperative x-rays of this patient. He underwent a T12 to L1 laminectomy for evacuation of abscess. And as discussed in the previous slide, he underwent a left-sided T12 transpedicular approach to access the ventral epidural space where there was abscess located there. Accordingly, there is no left T12 pedicle screw. However, there is instrumentation at T11 and L1 bilaterally with a right-sided T12 pedicle screw. The facets were burred down for promotion of arthrodesis, and additional bone graft material was packed over the transverse processes bilaterally following decortication of those bony surfaces. You can see a drain was left behind, and postoperatively he was transported to the recovery room in stable neurological condition. Following surgery, the patient's proximal lower extremity strength improved to the point that he was full strength in all muscle groups in the bilateral lower extremities. OR cultures came back positive for MSSA. The infectious disease team at the hospital was consulted, and they recommended placing him on nafcillin for 6 weeks, so he had a PICC line placed prior to discharge. The long-term plan was that he would be transitioned from the IV antibiotics to long-term PO suppression with cefadroxil. In these patients with a history of IV drug use, it's often important to also rule out cardiac seeding or sourcing for infection. This patient's fever and blood cultures had been negative, and all of his laboratory values improved pretty quickly after surgery. He did undergo a TTE, which was negative for any vegetations. Given the absence of persistent positive blood cultures or persistent fevers, it was not felt that it was necessary to undergo a more invasive form of cardiac evaluation to rule out valvular vegetations. The most likely source of infection for this gentleman was a left arm abscess, probably which had formed as a result of his heroin injections, which did require local source control by a general surgery. He ended up being discharged in stable functional and neurological condition and continued to do well in the postoperative setting, completing his IV antibiotics and then his PO antibiotics. Often a challenge in these patients is in the setting of a history of IV drug use. They can't go home with a PICC line in place, so they need to go to some sort of facility that can administer the IV antibiotics for a period of time until that PICC line is removed. Thank you very much for your attention. Hopefully this has provided some new insight for the identification and management of spinal epidural abscesses.